Hello everyone, and welcome to the Docsaab's Diary. Today we are diving deep into acute rheumatic fever diagnosis and management, a crucial topic presented straight from the Indian Academy of Pediatrics standard treatment guidelines. Acute rheumatic fever is rarely seen these days in some regions, but it remains a significant concern for our high risk Indian population. Let's begin our detailed look at these essential guidelines. Acute rheumatic fever is at its heart a fascinating yet devastating condition. The IAP guidelines state acute rheumatic fever, once a common acquired cardiac disease, is rarely seen these days. But then it clarifies considerable evidence supports the link between antecedent group A Streptococcus pharyngitis and acute rheumatic fever and rheumatic heart disease. So, a simple strep throat can lead to this complex immune reaction. It's not the bacteria directly attacking the heart, but our own body's immune system through what we call molecular mimicry. And not all strep infection do this. It's a specific concept of rheumatogenicidity. Only certain group A streptococcus strains like M types 1, 3, 5, 6, 14, 18, 19, 24, 27, and 29 have this power. Why some individuals and not others? That's where genetics come in. Polymorphisms in genes like interferon gamma, angiotensin converting enzyme, FCN, FCGRLLA, and HLA can increase susceptibility. These complex interplay of infection and genetics explain why acute rheumatic fever is so selective. While many developed nations now rarely see it, for us in India, acute rheumatic fever and its severe complication, rheumatic heart disease remain a pressing concern, making us a high risk population. Now we get to the core of diagnosis of the modified Jones criteria as updated by the American Heart Association in 2015. These are clinical manifestations backed by evidence of recent group A streptococcus infection. Let's break down the five major manifestations. First, carditis. This is the most serious. It can be subtle, where only echocardiographic evidence is present, what we call subclinical carditis, or it can be obvious with clinical murmurs from valvulitis. In severe cases, it can be pancarditis affecting all layers of the heart. Crucially, the guidelines emphasize the endocardial involvement is a must, and while mitral and aortic valves are commonly affected, isolated right sided involvement is rare. Second, polyarthritis. This is typically migratory, flitting from one joint to another. It involves large joints like knees, ankles, elbows, and wrist. Though it spares the spine and smaller joints, it is extremely tender to touch and shows a dramatic response to salicylate medication, meaning aspirin often works wonders. Importantly, it's never deforming, and fascinatingly, there is an invasive relationship between the severity of carditis and arthritis. So, if the arthritis is very severe, the heart involvement might be milder. Third, chorea, specifically Sydenham chorea. This is movement disorder, often accompanied by a emotional lability and poor coordination, which can even affect school performance. It has a long latent period after the infection, which means by the time it appears, the antibody test might no longer be positive. Fourth, erythema marginatum. This is rarer but very characteristic race. The guidelines describe it as erythematous, serpiginous, and macular lesions with pale centers. It's non-pruritic, meaning it doesn't itch and typically appears on the trunk and extremities, sparing the face. And fifth, subcutaneous nodules. These are also rare, firm nodules along the extensor surfaces of tendons near bony prominence. Their presence is often correlated with cardiac involvement. These five major manifestations are the pillars of our clinical suspicion of acute rheumatic fever. After complementing the major criteria, we have the minor manifestations and the essential supporting evidence of group A streptococcus infection. The minor clinical features include arthralgia or joint pain without objective signs of inflammation and fever. Our minor laboratory findings are elevated acute phase reactants, specifically an ESR and CRP, and a prolonged PR interval on the ECG. But none of these criteria, major or minor, stand alone. They must be accompanied by a supporting evidence of antecedent group A streptococcus infection. This is crucial. We look for a positive throat culture or rapid antigen test or elevated or increasing streptococcal antibody titer like ASO or anti-DNSB. The way we combine this for diagnosis is also important. differentiating between an initial and a recurrent attack. For an initial attack of acute rheumatic fever, we need two major manifestation or one major plus two minor manifestation plus supporting evidence of antecedent group A Streptococcus infection. For a recurrent attack, the rules are slightly broader. Two major manifestation or one major plus two minor manifestation or three minor manifestations plus supporting evidence of antecedent group A infection. This structured approach helps us navigate a diagnosis where no single test provides the answer. Now we encounter critical strategy risk stratification in diagnosis. This is a pivotal for us in India as the guidelines specifically adapt the Jones criteria based on population's acute rheumatic fever risk. Let's imagine two scenarios. First, low risk populations. These are areas with very low incidence of acute rheumatic fever, less than 2 cases per 1 lakh school age children, or low prevalence of RHD. In such settings, the diagnostic bar is higher. For major arthritis, only polyarthritis counts. For minor arthralgia, only polyarthralgia is considered. Fever needs to be higher more than 38.5 degrees Celsius and ESR must be more than 60 mm per hour or CRP higher more than 3 mg per deciliter. Now consider the moderate and high risk populations. This is our reality in India, where acute rheumatic fever incidence is greater than 2 per 1 lakh or RHD prevalence exceeds 1 per 1000. Here the guidelines become more flexible, allowing us to capture more cases. For major arthritis, monoarthritis or even polyarthralgia can be considered. For minor arthralgia, monoarthralgia is accepted. The fever threshold drops to 38 degrees Celsius and the ESR threshold is lower, more than 30 mm per hour and CRP still more than 3 mg per deciliter. The other major criteria, carditis, chorea, erythema marginatum, and subcutaneous nodules remains the same across both risk groups. This tailored approach details in the guidelines ensure that in the settings like ours, where the disease is more common, we don't miss diagnosis by using overly strict criteria. This means, crucially for India, monoarthritis can be major criterion in high risk settings. Let's talk about the essential diagnostic tools, echocardiography and ECG. The guidelines highlight that echocardiography is an important tool to confirm cardiac involvement in acute rheumatic fever. It is invaluable, especially for detecting subclinical carditis where heart inflammation is present but without a clinical murmur. The AHA 2012 criteria provide precise echocardiographic definitions. For Doppler criteria, all points must be met. For pathological mitral regurgitation, you need to see in at least two different views. The regurgitation jet must be at least 2 cm long in one view, its peak velocity greater than 3 meters per second, and it must be pansystolic, meaning it lasts throughout systole. Similarly, for pathologic aortic regurgitation, visible in at least two views, a jet length of at least 1 centimeter, a peak velocity greater than 3 meters per second, and it must be pandiastolic, lasting throughout diastole. Beyond Doppler, morphological criteria are also important. In acute mitral valve involvement, look for signs like dilated mitral annulus, elongated or ruptured chordae tendineae, prolapse of the valve leaflet, or nodular lesions. In chronic mitral valve involvement, which develops later, you might see thickened leaflets, fused chordae, limited leaflet mobility, or calcifications. For aortic valve involvement, both acute and chronic, we look for symmetrical or focal thickening of leaflets, disturbed coaptation, limited mobility, or prolapse. Finally, an ECG helps us identify a prolonged PR interval, a key minor criterion indicating delay conduction. Now we shift our focus to treatment principles. The guidelines state that acute rheumatic fever treatment has not changed in the last few decades and consists of mainly anti-streptococcal and anti-inflammatory therapy. We can summarize this approach into four core pillars. Pillar 1, eradication of group A Streptococcus. This is our immediate priority. We must eliminate any lingering gas bacteria from the patient's system. Even if pharyngitis symptoms have resolved, clearing the bacteria prevents further immune stimulation and drastically reduces the risk of recurrence. Pillar 2, anti-inflammatory therapy. Our aim here is to suppress the acute inflammation that causes all the clinical symptoms, the fever, the joint pain, and critically the cardiac inflammation. These not only provide symptomatic relief but can help limit tissue damage and especially in the heart. Pillar 3, supportive care. This involves crucial measures like bed rest during the acute phase, particularly for patient with carditis, and importantly, if patient develops congestive heart failure, we initiate standard CHF management protocols. Pillar 4, monitoring. Continuous and careful monitoring is essential. We track clinical symptoms, watch for complications, and regularly assess acute phase reactants like ESR and CRP to gauge the resolution of inflammation and the patient's response to treatment. These pillars guides every step of our management. Let's delve into the specific of anti-inflammatory therapy, focusing on aspirin and corticosteroids. For arthritis and cases of mild carditis without significant heart failure, aspirin is our primary agent. The guidelines describe the arthritis as having a dramatic response to salicylate, making aspirin very effective. We typically start with a high dose 75 to 100 mg per kg per day divided into 4 doses. This is continue for about 1 to 2 weeks until symptoms subside and inflammatory markers normalize. A crucial step then is to gradually taper the dose over 4 to 6 weeks to prevent rebound inflammation. When we face moderate to severe carditis, especially if it is accompanied by a congestive heart failure, systemic corticosteroids like prednisolone come into play. The dosage is typically 1 to 2 mg per kg per day, up to a maximum of 60 to 80 mg for 2 to 3 weeks. Like aspirin, corticosteroids also require a slow, careful taper over several weeks to avoid adrenal insufficiency and potential rebound in inflammation. Often, aspirin is introduced during the steroid taper. Lastly, for the management of chorea, medications like haloperidol or sodium valproate may be used to control the involuntary movements. It is important to remember, as the guidelines highlight, that chorea has a long latent period, so anti-streptococcal antibody test might be negative by the time symptoms appear. I have provided a practical sample dosing guide for acute rheumatic fever treatment. For primary anti-streptococcal therapy, using benzathine penicillin G intramuscularly, children weighing less than 27 kg receive 6 lakh units as single dose. For those 27 kgs or more, it is 1.2 million units also as a single dose. Regarding anti-inflammatory therapy, aspirin start at 75 to 100 mg per kg per day, divided QID, maximum 4 to 8 grams daily for adults. Continue 1 to 2 weeks until afebrile and ESR and CRP normalize. Then taper to 60 to 70 mg per kg per day over 4 to 6 weeks. Watch for GI bleeding, tinnitus, and salicylate toxicity. Prednisolone for severe carditis is typically 1 to 2 mg per kg per day, maximum 60 to 80 mg per oral twice daily for 2 to 3 weeks. Slow taper mandatory to prevent rebound. Start aspirin during taper. No long-term cardiac benefit over aspirin alone, but faster symptom control. For the management of chorea, haloperidol can be used at 0.025 to 0.05 mg per kg per day, titrated slowly. Watch extrapyramidal symptoms. Alternatives: valproate 15 to 20 mg per kg per day or carbamazepine 10 to 20 mg per kg per day. Liver function monitoring is essential. Finally, for secondary prophylaxis, the cornerstone benzathine penicillin G is given at 1.2 million units every 3 to 4 weeks. The duration we all see as critical. Penicillin allergy, then give penicillin V 250 mg BD or sulfadiazine 500 to 1000 mg daily. CHF backup, furosemide 1 to 2 mg per kg IV every 6 to 12 hours plus ECE inhibitors. Bed rest until ESR CRP normalize, typically 2 to 4 weeks. Now we discuss what is arguably the most crucial aspect of long-term acute rheumatic fever management, secondary prophylaxis. Its importance cannot be overstated. This long-term antibiotic therapy is vital to prevent recurrent acute rheumatic fever attacks, which with each episode cause progressive damage to the heart valves and can lead to severe rheumatic heart disease. The drug of choice remains benzathine penicillin G, given intramuscularly at 1.2 million units. The schedule is typically every 3 to 4 weeks. In our high risk settings like in India, an every 3-week regimen is often preferred to ensure maximum protection. The duration of prophylaxis is tailored to the severity of the initial episode and the presence of cardiac involvement. If there was no carditis during acute rheumatic fever episode, Prophylaxis continues for 5 years or until 21 years of age, whichever is longer. If there was carditis but no residual rheumatic heart disease, it is extended to 10 years or until 40 years of age, whichever is longer. And if there is carditis with residual rheumatic heart disease, prophylaxis must be lifelong. For patients with penicillin allergy, oral alternatives like sulfadiazine or macrolides are available. However, ensuring adherence to this long-term regimen is significant challenge requiring strong patient and family support. Let's briefly look at the horizon, future directions and unanswered questions in acute rheumatic fever. The guidelines further reading section points to ongoing research, including critical studies on risk factors by Baker, revisions to Jones criteria by Gavitz, and comprehensive reviews in texts like Nelson's. We continue to deepen our understanding of acute rheumatic fever pathogenesis and immunology. The quest for novel diagnostic biomarkers for earlier, more specific detection of acute rheumatic fever continues, especially for subclinical cases. Globally, the eradication of acute rheumatic fever faces immense challenges, often tied to socioeconomic determinants. Ultimately, the development of safe and effective group A streptococcus vaccine remains the holy grail for primary prevention, though challenges like antigenic variability and avoiding autoimmunity persist. These are the frontiers we continue to explore. Finally, I offer my sincere thanks and invite your questions. Let's quickly reiterate four critical takeaways. India is a high risk population. Remember, the criteria are adopted, so monoarthritis can be a major criterion for diagnosis. Echocardiography is crucial. It helps us detect subclinical carditis in up to 30% of patients, guided by the those precise EHA 2012 criteria. The arthritis in acute rheumatic fever shows a dramatic salicylate response, making aspirin a highly effective initial treatment for this manifestation. And most importantly, lifelong secondary prophylaxis with benzathine penicillin G is essential for patients with residual rheumatic heart disease. This is where we make the biggest difference in preventing further devastating complications. Thank you again for your time and attention. Please feel free to ask any questions or you can reach me via comments. And please like, share, and subscribe to the Docsaab's Diary.